Ms. Carey.
My lady, I know you've heard about DNA CPRs from your meetings with the bereaved groups, and so I turn to this topic next. It is undoubtedly a highly emotive topic, and so I'd like to spend a moment explaining DNA CPRs. Some of people following this may find some of the detail distressing, and so there may be people that either wish to leave the hearing room or rejoin the link in a moment or two. Cardiopulmonary resuscitation, or CPR, is an emergency procedure that aims to restart a person's heart if their heart stops beating or they stop breathing. It can involve chest compressions, delivery of high-voltage electric shocks across the chest, attempts to ventilate the lungs, and injection of drugs. It is, as you will hear, an invasive and traumatic medical intervention, and most CPR, sadly, is unsuccessful. The survival rates are relatively low. In hospitals, the average proportion who survive is 15 to 20%. Out of hospital, the survival rate is lower. Due to the nature of the treatment, in some circumstances, CPR can do more harm than good and can cause physical injuries to the patient, in particular to their lungs and ribs. A DNA CPR notice sets out a decision not to attempt CPR. They are designed to protect people from unnecessary suffering by receiving CPR that they don't want or that won't work, or where the harm outweighs the benefits. May I make this clear? It is a specific decision made in respect of CPR alone, and it is not a decision not to treat. It should not and must not be confused or elided with an advanced care plan, which is commonly the umbrella term used for a document which records individuals' preferences and decisions about their future care and treatment. DNA CPR decisions are made or should be made based only on clinical judgment, usually by the clinician responsible for the person's care. And wherever possible and appropriate, a decision about CPR should be agreed with the whole care team involved in the person's care, and wherever possible, made in consultation with the person. A person can state that they do not want CPR to be attempted as part of their advanced care planning, and that will be taken into consideration by the clinicians who are making decisions. The General Medical Council has issued guidance that makes it clear that if the patient lacks capacity to make a decision, a legal proxy, for example, a power of attorney, may in fact make the decision for the patient, but they must be consulted unless it is not practicable or appropriate to do so. And if there is no legal proxy, the matter then must be discussed with those closest to the patient and with the healthcare team. Now, during the course of the pandemic, there were reports of blanket DNA CPRs being imposed. For example, the BMA heard reports of GP practices sending blank DNA CPR forms to patients over 65 or to those with a disability. There are also reports of DNA CPRs being used inappropriately. The four nations' departments communicated with healthcare professionals in a variety of ways and at various times to remind healthcare professionals or to reiterate that any DNA CPR decision was being made on the particular and individual circumstances of each patient, and that it was unacceptable to apply DNA CPRs to particular groups. I think you may have heard that the DHSC commissioned the CQC to look at DNA CPR decisions. Their interim report found that there was confusion and miscommunication about the application of DNA CPRs at the start of the pandemic and a sense of providers being overwhelmed. CQC found there was evidence of unacceptable and inappropriate DNA CPRs being made. But they did note there was a quick response from multiple agencies to highlight the issue. They remained concerned, however, that there were some cases inappropriate DNA CPRs remained in place. And the CQC's final report in March 2021 found what the CQC described as a worrying picture of poor involvement, poor record keeping, and a lack of oversight and scrutiny of the decisions being made. CQC considered there was significant impact and distress caused where discussions about DNA CPR decisions did not take place at an appropriate time. Every Story Matters has heard accounts of how some people only discovered a DNA CPR being put in place after their loved one had died or after they were discharged from hospital. To quote just one contributor, they said this to Every Story Matters: "We didn't know he had a DNR, and my mum had a power of attorney. The only reason we know is because when he was discharged, it was in his pack. But the fact that we weren't involved in the decision, knowing that Dad's got Alzheimer's, it kind of felt like they were throwing away old people. It was like they're not a priority because they're old." That lack of communication, plus the concerns about blanket and inappropriate applications of these notices, are matters raised by the representatives from the COVID-bereaved core participant groups, who will give evidence about the DNA CPRs and a whole range of their other concerns at the beginning and indeed at the end of the public hearings. I mentioned there that the bereaved core participant groups are the first witnesses to be called across the UK, and you will hear about the circumstances in which their loved one died and the impact this had and continues to have on them and their families. Every Story Matter report includes a chapter on end-of-life care and bereavement, and it records the pain, upset, guilt, and often anger expressed by those who could not be with their loved ones in their final days. To quote just one contributor who said this: "My mother was lying on a bed with something out of space standing by her," a reference to staff in PPE. "She was being told to wave to her family on an iPad. She waved like a child and the Zoom call ended. The doctor told her she's not going to wake up again, and so she waved so hard to say goodbye to her family. I couldn't believe the doctors had told her that she wouldn't wake up after the ventilator. We watched our mother on an iPad, on a ventilator, dying." Now, my lady, whilst the need to prevent the spread of infection in hospitals was clearly a very key consideration in not allowing visitors, not being at the bedside of a dying loved one, it has caused the most immense pain and harm. Many of the witnesses you will hear from do not suggest anything other than this was a difficult balancing act. But, my lady, this is one area you may feel that the UK may need to act differently if there were to be a future pandemic. You may think it cannot be beyond the capabilities of our society to provide dignity in death, to facilitate visits at the end of life. And these may be matters that you'll wish to consider both in this and indeed in future modules. Protecting the vulnerable was clearly an aspect to the shielding programme. There is both the clinically vulnerable, the clinically extremely vulnerable, and those at highest risk, as they were renamed in Scotland in June 2021. This was a priority for the healthcare systems across the UK, and it was the chief medical officers who decided the initial groups they considered to be at highest risk, and groups were added as the pandemic progressed. Initial shielding advice was issued across the UK from about the 21st of March onwards in 2020. And those who were deemed to be clinically extremely vulnerable were advised to shield for at least 12 weeks by staying at home as much as possible, except for attending essential medical appointments or for exercise. And they were advised to avoid face-to-face contact with people outside their household. Now, that created real practical difficulties for those who required medical appointments, required repeat prescriptions, conditions that needed monitoring, as well, of course, as the going about one's daily life and the usual routines of going to the shops. That 12-week period was extended and then overlapped with periods of lockdown over the following 18 months with local variations. People identified as being clinically vulnerable included those over 70, pregnant women, and those with a chronic condition or morbid obesity. Now, they were also told to stay at home as much as possible and to be strict in social distancing. But the clinically vulnerable were not included in the shielded patient list and did not receive letters or support to self-isolate through the shielding initiative. That created, you may hear, a degree of additional stress and concern at the lack of support and advice they received. My lady, the decision to require large numbers of the population to shield is not without its supporters and indeed its critics. And whilst the role of non-pharmaceutical interventions was something you've already examined in Module 2, there are particular aspects of the shielding programme which Module 3 will examine. Some of those issues include the decision-making process to identify those deemed as clinically vulnerable and at highest risk, how that was communicated to those groups, how it was decided to pause the programme, restart it again, finally stop it. The dates of those decisions varied across the UK, and not every nation restarted the programme. And you will want to consider how those who were shielding accessed healthcare, and more generally the impact of the shielding programme on those who were shielding. Many people have spoken of the significant and deleterious impact shielding had, including to Every Story Matters, on their physical and mental health. Indeed, you will hear impact evidence from Dr. Catherine Finnis on behalf of the core participant group, Clinically Vulnerable Families. She will be able to attest to the ways in which group members were affected, and indeed Professor Snooks will speak to a number of aspects of the shielding programme and of the difficulties in evaluating its efficacy. One other matter that you have heard about is long COVID. Long COVID is the term used to describe the ongoing symptoms caused by COVID-19. Sometimes it's referred to as the post-COVID-19 syndrome, but I'm going to use the phrase long COVID if I may. During the course of Module 2, you will recall hearing from Professor Breitling and Dr. Evans. They prepared an addendum report for Module 3. They explain that long COVID is frequently characterised by fatigue, breathlessness, brain fog, joint and muscle pain, but there are in fact over 200 symptoms that have been reported, and studies have shown the reduction in quality of life and significant impacts on the sufferer's ability to continue to do the job they did before developing long COVID. In some cases, their ability to do a job at all. It is not easy to diagnose, as you know. Evidence provided by the long COVID core participant group attests to concerns about the length of time taken for their members to have their symptoms taken seriously, and their members report having their symptoms disbelieved and or minimised. And that echoes accounts given to Every Story Matters. The experts will tell you that any adult is at risk of developing long COVID, although it is more common and more likely to be severe in females and those with pre-existing health conditions. People who are not hospitalised during their COVID infection can suffer from long COVID symptoms that are just as severe as those experienced by people who had been hospitalised. Access to healthcare for long COVID has been and remains variable within and across the 4 nations of the UK. There are long COVID clinics in October, started in England. In Northern Ireland, there was funding granted in November 21 for a dedicated assessment and treatment centre. And whilst there don't appear to be long COVID clinics in Wales and Scotland, there was funding allocated in both countries for long COVID care and rehabilitation. ONS data suggests that the vaccination prior to infection reduces the likelihood of developing long COVID. And my lady, clearly healthcare workers were at a higher risk of exposure to COVID-19 infection throughout the pandemic, with early studies highlighting the risk of severe disease associated with certain ethnic minority backgrounds. According to the Chief Medical Officer's technical report, the precise number of people who've experienced longer-term symptoms after COVID is likely to be substantial but remains unclear. In July 2022, the ONS estimated it was 1.4 million people in the UK. By February 2023, the ONS estimated the prevalence to be over 2 million people in the UK. In my submission, those estimates are a powerful reminder why considering the long-term consequences of pandemic diseases need to not only be recognised at the start of the pandemic, but planned for wherever possible. And I know you will want to examine the extent to which long-term consequences of COVID were considered as part of core decision-making in those early days. Module 3 has within its scope reference to non-COVID conditions. The decision to suspend all non-urgent and elective surgery has had and continues to have a significant effect on non-COVID related healthcare. Now, clearly it would not be practical or realistic for the inquiry to look at the impact on every single illness or treatment that was stopped. And so Module 3 has selected some common and important health conditions to examine in more detail. There are 4 in total, and I will briefly deal with them. Instructed to help in this task are experts in those fields, and in particular to look at the impact of COVID on diagnosis, care and treatment of the non-COVID conditions, and how treatment and diagnosis were maintained during the pandemic, the impact of the delays, impact of the delays on diagnosis and treatment on patient outcomes and on the patient's health. The first of those conditions is ischemic heart disease. That is the most common form of heart and circulatory disease, affecting over 2 million people in the UK. Often it manifests itself as a heart attack or an angina when the heart does not receive enough blood and oxygen. Professor Gale, the module's expert, states that the pandemic witnessed a substantial decline in people being admitted to hospital with heart attack. He notes that the onset of the decline in admission was before the first UK lockdown, and states that although it's not known why this occurred, he considered it maybe because the public were fearful of coming to the hospital and or wanted to protect essential clinical services for people with COVID-19, and or sadly they died in the community. That is a theme I suspect you will hear running throughout the non-COVID conditions and indeed other evidence. He states that during the pandemic there were more deaths from acute cardiovascular causes than expected, and whilst hospital remained the most frequent place of death, there were proportionately fewer deaths in hospital and more deaths at home. He considers that the data suggests the public either did not seek help for suspected heart attacks or were not referred to hospital for suspected heart attack. And he warns that the consequences of delay will lead to many more adverse health consequences. He considers that during the early part of the pandemic, there was a deficit of public information about the importance of attending hospital with symptoms of a heart attack. The inquiry is also going to look at colorectal cancer, also called bowel cancer. That is the 4th most common cancer in the UK. The 2 experts instructed consider that there was a substantial reduction in the number of patients diagnosed with bowel cancer during the first wave of the pandemic across all referral pathways, except for emergency presentations, which remained constant. In the first phase of the pandemic, there was a sharp fall in referrals for suspected colorectal cancer and subsequent diagnostic tests. The experts consider that in the order of 3,000 to 4,000 patients from England, 750 to 1,000 patients from Scotland, 500 patients from Wales, and 150 from Northern Ireland missed a diagnosis. The experts' critical recommendation is to keep the pathway of cancer services, meaning from diagnosis through to treatment, open during the next pandemic. And they consider that ring-fenced elective surgery hubs should be more widely used to provide COVID-free pathways. The inquiry is also considering hip replacement surgery. Now, whilst the suspension of hip replacement surgery was not life-threatening, evidence suggests that delaying hip replacement surgery was life-limiting. The inquiry's experts will tell you that the most common reason for hip replacement is painful osteoarthritis. And the hip arthritis is very common. It's about 8% of the UK population over 45 that have sought treatment for osteoarthritis of the hip. Professor Metcalfe and Ms. Chloe Scott will tell you that where patients have worse hip pain and function, they have worse health-related quality of life prior to their hip replacements, but they also achieve worse patient-reported outcomes after surgery. They will tell you that the pandemic led to an increase in patients attending orthopaedic clinics for the first time in wheelchairs who'd already lost their mobility and who'd missed the opportunity to have a hip replacement in a timely fashion and who are now not suitable for hip replacement due to their frailty. One of the recommendations they ask you to consider is that in the event of a future pandemic requiring suspension of elective surgery, there should be a body committed to planning the prompt restoration of safe elective care. They consider that such planning needs to include specific recovery targets with incentives for regions and trusts to deliver them. And the final non-COVID condition is the inquiry considered it important to consider the impact of the pandemic on inpatient mental health services for children and young people. The deterioration in the mental health of children and young people during the pandemic was stark. A statement from the chair of the Royal College of Psychiatrists, Faculty of Child and Adolescent Psychiatry, makes clear that the rates of probable mental health disorders rose during the relevant period. There's particular concern for children and young people with eating disorders, and demand for those services increased substantially, as did the number of children and young people presenting with severe eating disorders. The experts instructed in this area will tell you that the pandemic affected the provision of inpatient treatment in a number of ways. It increased the waiting time between referral and admission. There was a substantial increase in time taken from the decision to admit to actually being admitted onto a psychiatric inpatient ward. The self-isolation rules resulted in new patients who were admitted requiring varying lengths of self-isolation. The experts will tell you that all of these issues are likely to have increased the length of stays and delayed the recovery of the young person. They are just some of the impacts set out in the experts' report, and it may be that the consequences of the pandemic on the mental health of children and young people will be matters that will resonate with the evidence that's gathered in Module 8, which is specifically looking at the impact on children and young people. My lady, Module 3 will also consider the impact of the pandemic on pregnant women seeking maternity care, including access to antenatal and postnatal care. The prospect of attending maternity appointments, going into labour, and sadly in some cases receiving devastating news about a pregnancy alone, and whilst IPC measures were in place, were the realities for those seeking and providing maternity care. You will hear there is a reluctance by some pregnant women to seek medical attention, whether that's through fear of themselves and or their baby catching COVID, or concerns about not overwhelming the NHS, or both. There was a healthcare services safety investigation branch who undertook an independent investigation. They investigated 19 maternal deaths in England between March 2020 and May 2020. And they found that the families were concerned about their health and the risk of exposing their unborn baby to COVID-19. Because of those concerns, they put off going to hospital for longer than they may otherwise have done. The evidence provided to the inquiry overwhelmingly suggests that having to attend appointments and being given unexpected and or upsetting news was one of the most distressing aspects of the pandemic. The Miscarriage Association conducted a survey, and amongst many of the quotations from that survey were these two. "It was heartbreaking to lose my baby, the only child I conceived in a 3-year ongoing infertility journey. Confused, masked, distraught, and without my partner to hold my hand and grieve with me." Another lady said this: "It was one thing being completely alone in hospital when having my miscarriage confirmed and having to decide how to manage things. But knowing that the government were having parties at the same time is disgusting and fills me with so much anger. I remember meeting my husband at the entrance to the hospital to decide on how to manage things. I'll never forget the group of men standing there, waiting for their partners to come out from appointments and scans. It was so inhumane, and a memory I'll never forget." It echoes an account given to Every Story Matters, where one contributor said this: "I went to a routine midwife appointment, but she was worried about the baby and said she couldn't hear a heartbeat. She said I needed an emergency ambulance or to make my way to hospital quickly. We drove to the hospital where they were expecting me. At the doors, I was told I was the only one allowed in. We thought that the baby had died at 32 weeks gestation, yet I had to go in alone. This was one of the scariest moments of my entire life. Meanwhile, my partner had to wait outside the hospital, waiting to be told if his baby was alive or not." There appears to have been inconsistency about the rules for visitors attending appointments throughout labour and indeed afterwards. The pandemic affected decisions about where to give birth and the types of birth that women would have liked. In some areas, for example, home births were suspended and midwifery-led units were closed. There were the concerns about staff shortages and PPE, and concerns about the impact of the pandemic on pregnant Black, Asian, minority ethnic women, where the evidence emerges is that they were at higher risk of experiencing severe COVID symptoms. Now, having considered the Module 3 non-COVID conditions and maternity care, my lady will now see that however necessary it was to tell the public to stay at home, protect the NHS, there was an undoubted impact on people who needed care for non-COVID conditions in a way that may not necessarily have been intended. Indeed, there is evidence that irrespective of the condition, there was a reluctance by many to not attend hospital. Across the UK, there were public campaigns to address any perception by the public they should not present themselves to the NHS for fear of catching COVID, or because they didn't want to be a burden. The Scottish Government launched NHS is Open. In England, there were campaigns such as Help Us, Help You and Open for Business. In Northern Ireland, there was a GP Mythbuster published, which sought to reinforce that GPs were still open. And in Wales, there were similar messages put out by the Welsh Government and through local partners and authorities to highlight the NHS was there for people who needed urgent care. The success or otherwise of those campaigns will be explored as the hearing progresses. As I mentioned earlier, Module 3's request for evidence have asked the recipients about the lessons they and their organisations have already learned. That includes the systemic issues that arose. They were asked to provide your ladyship with recommendations for you to consider. And as the evidence unfolds, witnesses may be asked about possible recommendations, not because the inquiry has prejudged matters, but so that those who may be responsible for implementing them can assist as to how workable they are, how efficacious they might be. That a recommendation is not asked about does not mean it has been dismissed or not be considered, simply that it's not possible to ask every witness about every recommendation. And so may I turn to where I started and the impact of the pandemic on those receiving and providing care. There is a further impact that deserves to be highlighted. Many of the witnesses who speak on behalf of those working in healthcare systems have attested in their statements to the gratitude to the staff who work tirelessly to look after us all, often at the detriment of their own physical and mental health. I know that in previous modules you have heard and indeed condemned the abuse that public servants were subjected to for the decisions they made, and sadly you may hear more of that within these hearings. It is nothing short of an outrage. There are some members of our society that think it is appropriate to insult and in some instances physically threaten individuals and their families who were doing their jobs to try and protect us all. Now, that is not to say that decisions should not be scrutinised, and there will undoubtedly be legitimate arguments and differing points of view about the reasonableness or otherwise of the decisions made. But I know that your ladyship will wish to denounce the increase in personal attacks and abuse that is meted out by those who are often ill-informed and may be ignorant to the additional harm they have caused. Although the public health emergency phase of the pandemic has ended, the myriad effects of the pandemic are still keenly felt by those providing healthcare and those receiving healthcare in the UK today. They are felt by those who are suffering from long COVID, whose treatment was delayed, the many thousands of healthcare workers left feeling completely and utterly exhausted and burnt out by the work they undertook and the efforts they went to look after us, and by those who deeply miss and mourn the friends, family and colleagues that died. And that, my lady, is why in my submission, Module 3's findings and recommendations are of such significance to each and every one of us who has the benefit of access to healthcare, which is available to all, based on clinical need and not on an individual's ability to pay.
Thank you very much indeed, Ms. Carey. I'm extremely grateful to you. I've also received written submissions from the core participants, and I'm very grateful to all of them. They're extremely constructive and helpful, but as a result, I'm afraid I'm going to have to ask the core participants to highlight only the most essential issues in their oral submissions. We have submissions from 29 core participants to get through before we call evidence from bereaved witnesses tomorrow afternoon. So to be fair to other core participants and to be fair to the bereaved witnesses, whom I don't wish to keep waiting, I'm afraid I must be very strict on timings. Right, I think Ms. Sweeney, sorry, I always struggle, you know I do. Casey, would you like to go first on behalf of the Welsh bereaved?
Thank you, my lady. COVID Bereaved Families for Justice Cymru is a group that consists of a spectrum of families bereaved by COVID in Wales. They're reluctant campaigners for truth, justice and accountability. It's heartbreaking to remember that there have been well over 12,500 deaths from COVID in Wales, yet a Welsh-specific public inquiry has been refused by the Welsh Government, so that this group is committed to securing scrutiny of all decision-making relevant to Wales in this inquiry. It's axiomatic that lessons must be learned, errors publicly acknowledged, and recommendations made for improvement in Wales. We appreciate the reassurances from the inquiry that the experiences of all 4 nations will be addressed, and we acknowledge that this is not a small undertaking. For this group, it is vital that the inquiry reflects that there are important features specific to Wales. Wales has complete responsibility for its own healthcare, and the Welsh Government remained responsible and accountable throughout the pandemic for strategic decisions and policy affecting Wales, where the population is older, poorer and sicker than in England. There were higher levels of nosocomial infection in Wales than in England or Scotland, at least in the first wave. This group has questioned how the responses of the Welsh Government, the NHS in Wales, 7 regional health boards, Public Health Wales and many other groups are to be scrutinised in this extensive inquiry, and to what extent that is a realisable ambition. The Chair may no doubt recall that our request for a split module by nation, as with Module 2, was refused. The Module 1 report has already highlighted that there was in Wales a very complicated array of committees, teams, groups and subgroups. It was, in quotes, labyrinthine. Although Wales had its own expert medical and scientific advice, the inquiry has concluded they were not central to pandemic preparedness and resilience. So health services in Wales were unprepared for a pandemic, and this is despite a series of exercises from as long ago as 2003, modelling emergency health responses in Wales. Even leaving actual science aside for a moment, we say the inquiry has available to it overwhelming evidence of catastrophic failures of common sense and pragmatism, which had devastating consequences for the people of Wales. Was it rocket science to practice caution in the face of a rapidly rising global death rate rolling towards Wales like a tsunami? What is the cost of caution in the face of death? Is it rocket science to provide the most effective PPE in the face of uncertainty, to cascade clear IPC guidance that does not overwhelm or disenfranchise overworked healthcare workers, to provide protection and dignity to the vulnerable and the elderly? Or is the Welsh experience the consequence of serious and serial incompetence on the part of the Welsh Government and its counterparts in the UK? Is this the tale of incompetence wagging the dog of a nation's health and safety, or is the appropriate cliché that of a headless chicken? This group want accountability for failures of governance and leadership on critical healthcare provision, in particular from the Welsh Government. Blaming the UK will not be an adequate response in light of the proliferation of dedicated Welsh committees and experts. On evidence, the group is struggling to see how the Welsh experience can be thoroughly examined by this inquiry. Apart from this group, witness statements have been provided by a range of Welsh-specific witnesses, though only a small handful are being called to give oral evidence to have their accounts tested through questioning. This leaves the rest to be taken as read. How then can our criticisms of Welsh pandemic healthcare be properly explored with all Welsh witnesses? A quick illustration is that the inquiry has directed us to ask our questions about, for example, the TUC to a relevant Welsh witness. But Adam Morgan, who has provided a Rule 9 witness statement from the TUC in Wales, is not being called. So we have to turn elsewhere. We will, of course, be pursuing Welsh evidence with all witnesses as appropriate, but it is an indirect process of challenge or inquiry that defies reliable aim or answers. The Welsh Government testimony will come from on high: Frank Atherton, Vaughan Gething, Barras Eluned, Morgan and similar. The group do not consider that a high-level gloss on what was happening in Wales will adequately discharge the commitment to inquire into Welsh processes. The shield of hindsight must not be wielded once more by Welsh Government witnesses. And there are issues of credibility to surmount. The inquiry has already encountered this with the deletion of Welsh Government WhatsApp communications and now iMessages, which remain under investigation. The Welsh Government has also been slow to provide its evidence in this module, necessitating the use of Section 21 notices by the inquiry. In relation to expert evidence, as far as we can tell, none bar one, Professor Edwards of Cardiff Hospital on primary care, is able within their professional expertise to opine on what happened in Wales. It's not considered proportionate continually to ask experts, what about Wales? Yet that is usually the first question on this group's lips. We consider it imperative that the inquiry is alert to probe the experience in Wales with all witnesses. Any gap in expert evidence in particular will, we fear, make it difficult for the inquiry to draw conclusions and make recommendations on untested Welsh evidence, save to the extent that it does not appear on paper to comply with experiences in other devolved nations, and especially England, to which the preponderance of expert evidence applies. There is danger, we say, that conclusions will be skewed towards England and risk not being applicable to the different systems in Wales for the future. On issues, our written submission is a distillation of some of our main areas of concern. And this has not been an easy task because every issue is a key issue for one or other member of the group. Across Wales and across all 4 nations, ordinary folks needlessly lost their lives. Their stories are a central part of this inquiry. The accounts you will hear from this group chime across Wales with systematic failures of healthcare at their heart through waves 1 and 2. Some of the stories frankly beg a belief. They bring into graphic relief the passive, disjointed and technocratic responses from the Welsh Government, leaving hospitals and staff floundering in the face of an unfolding disaster. A common theme in these stories is that COVID was acquired in hospital, sometimes a week or more after admission for non-COVID related reasons, for a minor leg operation, a kidney infection, or seriously heart condition and suspected sepsis, or after a negative COVID test. That the source of the infection lay within the hospital is clear in many stories. One member's loved one was moved from ward to ward, an infection control technique criticised by the Welsh Government's nosocomial investigation recently published. He caught COVID and died in ICU. There are many such stories. Vulnerable people at high risk through existing health conditions were at more risk in hospital than when shielding in the community. One member's loved one with an autoimmune disorder was placed on a main ward after a negative test on admission. Members recall seeing nurses wearing inadequate PPE or failing to renew PPE as they moved from one part of a hospital to another, and nurses walking around with face masks on their chins. A member recalls being asked to wear full PPE when visiting relatives, yet nurses wore none. Elderly and frail people were refused or had treatment delayed or were coerced into accepting do not resuscitate notices. One member was told her mother was being refused oxygen therapy based on her frailty score. There are scores of stories of failed contact with GPs, out of hours, 111 and 999 services. There was no dignity in death. One health board authorised staff to move around hospitals, taking photos of those who were suffering and dying, and also after death. This group says it is clear that the evidence in this module will show that hospital-acquired or nosocomial infection was not inevitable. It was a result of a basic misunderstanding of IPC. During the first wave, the First Minister and Health Minister in Wales said that there was no value in regular testing of healthcare workers without symptoms, even as WHO advice in June 2020 was to the contrary. There was good evidence available early in 2020 that COVID is an airborne virus transmissible asymptomatically. It will not be enough for the Welsh Government to be allowed to say they were simply following or collaborating with the UK Government in these critical matters. They had their own experts, their own version of SAGE, their own nosocomial transmission group. No buck passing is the key message. Finally, in summary, the group requests that this inquiry listens to Welsh voices, scrutinises care in Wales from GPs, ambulance services, in hospitals and after death, ensures there is accountability in Wales for the catastrophic rate of hospital-acquired infections, ensures accountability for the IPC guidance that we say did not follow available science, ensures accountability for the delay in rolling out the regular testing of healthcare workers to March 21, scrutinises the use of clinical frailty scores, treatment escalation plans, and do not resuscitate notices for the vulnerable, including the elderly in Wales, fully explores the consequences of IPC of ageing infrastructure and buildings in the NHS in Wales, finally ensures that lessons are learned from Welsh experiences and recommendations can be made for Wales to ensure safe health systems for the future. That completes our opening statement.
Thank you very much, Ms Atney. Very grateful. I think Ms Mitchell.
My Lady, I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID Bereaved. The Scottish COVID Bereaved is a group of bereaved individuals with a common goal, wanting lessons to be learned from the deaths of their loved ones to stop others having to suffer in the same way that they have. They hope that in sharing their experiences, they will be of assistance to the inquiry, and indeed the inquiry is heard this morning from one of our members, Carol Ann Stewart, and we'll hear from others later in the module. Their experiences and the experiences of others in the UK provide a visceral reminder of the pandemic's devastating impact, and we are grateful to them for sharing these very difficult, emotional and sensitive details of their life so that we may learn from them. The group has been consistent and positive media presence and has political campaigning. The bereaved have identified areas of concern amongst their members and have shared these concerns with politicians at this inquiry and its Scottish counterpart. The group has repeatedly raised the issue of deaths of patients with hospital-acquired COVID-19 infections. They have raised issues around NHS services and the suitability of testing criteria focusing on the 3 cardinal symptoms. The group has also proposed that the Crown in Scotland investigate deaths into care homes and should also consider the issue of nosocomial deaths. As well as this, the Scottish COVID Bereaved has and have supported their members. Groups have been set up to support members who are bereaved as a result of COVID in care homes and through nosocomial infection. Mutual support is offered to members through the closed Facebook group. The group holds online meetings which not only allow for members to be kept up to date in relation to the ongoing inquiries, but allows them to share their stories and ask for help. Turning then to Module 3. In Module 1, the bereaved learned that despite the existence of pandemic planning exercises and various expert groups, neither Scotland nor the wider UK were in any way prepared for the pandemic which struck. In Modules 2 and 2A, the inquiry examined the core political and administrative decision-making in Scotland and Westminster. A spotlight was turned on our politicians, civil servants and advisers. Those we trusted with our health and our lives were often found lacking. It's hoped that the inquiry, light being shone on the topics in Module 3, will be the disinfectant required to place Scotland and the United Kingdom's healthcare systems in a better place in the future. As the bereaved have previously submitted to this inquiry, and as the World Health Organization sets out in its constitution, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition. While, of course, the Scottish COVID Bereaved focus is on Scotland, each and every one of us in the United Kingdom was affected in some way by the decisions taken in relation to healthcare. Whether that be those like the bereaved who lost loved ones, those who risked their life to staff hospitals and care homes, and those who watched family and friends struggle through treatment, or those whose care for non-COVID related conditions was affected. In the course of this hearing, the bereaved hope that they can find answers to questions, some of which have been asked since those devastating early days of 2020. And those watching online and present here today will have noted with great interest the detailed and helpful opening statement by Senior Counsel to the inquiry, setting out all the areas that are to be considered. This is very helpful in putting at ease the minds of the bereaved who are keen to ensure that all issues are dealt with. And this opening statement will no doubt go a long way in that regard. The bereaved are particularly interested in the inquiry's examination of a number of issues, and I will give my lady a short following list which is not exhaustive or set out in any area of importance. And of course my lady will have heard these already in much greater detail. The healthcare provisions and treatments for patients with COVID, decision-making about the nature of healthcare to be provided for patients with COVID, do not attempt cardiopulmonary resuscitation, communication with patients with COVID-19 and their loved ones about patients' conditions and treatments, again including discussions about DNA CPRs, the impact of those requiring care for reasons other than COVID, issues impacting upon palliative care, the discharge of patients from hospital, infection prevention and control measures, the adequacy of PPE, nosocomial infection, restrictions on visiting patients, and shielding and the impact on the clinically vulnerable. The Scottish COVID bereaved have heard and understood the need for focus to be brought on questions for witnesses, and hope only to pose questions where it is thought necessary to obtain evidence to assist the Chair in making recommendations. The group, of course, has equal interest in all the UK relevant witnesses. The bereaved do have other issues in relation to this module, including questions for the former CMO, Dr. Catherine Calderwood. And the purpose of the foregoing list was not to list every area of concern, rather it's hoped these examples provide to the Chair an example of the breadth and depth of the issues which the bereaved hope can be covered in the forthcoming weeks. It's been clear to the Scottish COVID bereaved that the political machinations and decision-making processes highlighted in the previous modules attracted a great deal of media attention. It's hoped that those in the press maintain this interest when the inquiry looks at the sometimes technical and complex healthcare decisions that were made during the course of the pandemic. The decisions made had an unprecedented impact on the health and lives of the nation, as of huge importance to us all. Finally, the bereaved appreciate that this module and the inquiry cannot change their experiences and the experiences suffered by their loved ones. The bereaved hope that the evidence that they will hear over the forthcoming weeks, as well as giving them the answers they seek, will help to ensure that our vital healthcare system and those who risked so much to staff it are in the best possible position when the next pandemic comes. These are the submissions of the Scottish COVID bereaved.
Thank you very much indeed, Ms Mitchell. Very grateful. Mr Woolcock, I think you're next.
I make these opening remarks on behalf of the Northern Ireland COVID bereaved Families for Justice. And in doing so, can I say that we are grateful for the thorough overview of this module that we have heard this morning from Ms Carey, King's Counsel. And we also appreciate that you have the benefit of assistance from over 30 core participants, all of whom you will want to hear in opening, to help you in this module. And many of these core participants represent organisations or individuals with huge scientific, technical or professional knowledge of the issues you will be considering. However, those whose loved ones died because of or for want of access to health care, and those who were providing the actual frontline care can tell you about the tragic truth of that experience, thus demonstrating that throughout the topics you will be investigating, the healthcare system choices being made, directly or indirectly, were not just theoretical, but had real consequences upon untold numbers of real people. And to that end, we adopt the representations we have previously made in writing and which have been made by other bereaved family groups today on individual topics included in this module, such as visiting restrictions, DNA CPRs, and the all too frequent lack of communication which continue to cause those that we represent great anguish. The campaign that I represent are particularly anxious to assist this inquiry in ensuring that the response of the Northern Irish healthcare system to COVID and the dreadful impact that that pandemic has had on the Northern Irish healthcare system, patients and healthcare workers, are as fully dissected in this module as we have been repeatedly assured that they will be. And to this end, you will hear from two of our members, Catherine Todd and Martina Ferguson, who will describe the suffering and feelings of loss surrounding the deaths of their newborn child and elderly mother, respectively, as well as providing an overview of the experiences of other bereaved families in our group in order that the inquiry can best assess the high-level evidence before it about the impact of COVID-19 on people's experience of healthcare in Northern Ireland against the real experience of those who were at the mercy of that healthcare system during the pandemic. My lady, impressions matter. This morning, we watched some powerful and moving testimonies in the impact video prepared for this module, all of which must be heard and heeded. I'm bound to say that members of the group I represent quickly noticed that the video contained no Northern Irish voices, whether bereaved or frontline workers in the healthcare system. And it may be that the inquiry intends to address that balance when the second impact video is shown in the second half of these series. However, this is not just about including different accents. As you will have seen from your journey around the UK earlier this year, whilst many of the experiences during COVID are universal, there were and are distinct differences between the health systems in the four nations of this country and between Northern Ireland and Great Britain in particular. When we addressed you in Belfast last May, we observed that the political similarities in Northern Ireland then and at the outbreak of COVID in March 2020 were obvious. Unfortunately, we can say exactly the same about the state of the healthcare system, which just 10 days ago was described by the Northern Ireland Director of the Royal College of Surgeons as remaining, and I quote, in a precarious state with huge pressures on a depleted and stretched workforce. But, my lady, you knew this already, because on the 10th of July last year, Sir Michael McBride, the Northern Irish CMO, told you when giving evidence that, and I quote, in Northern Ireland, the health service struggles on a day-in, daily basis to deliver what it should be delivering. Notwithstanding the additional pressures created by the pandemic and surge, where really what we had to do was to turn off to a large extent all of that elective capacity, which had huge impact right across the public, leading to, I continue the quote, people waiting excessive periods of time, even longer than they were before. The worst waiting times in the UK got even longer. People waited in pain and distress, and we are still not in a position where we can recover. Now, that answer came at 4:15 in the afternoon, and pressure of time meant that Sir Michael was unable to say more. He is, however, I think, one of the few, I think it's only 5, professional or political Northern Irish witnesses being called in this module of the inquiry, who can provide you with the further detail you may feel you now require in this module. One of these witnesses will tell you about Altnagalvin Hospital in one of the poorest areas in Northern Ireland, where many staff live in a short distance away in the Republic of Ireland in Donegal, and which has staffing problems, partly, she says, as a result of more attractive terms and conditions for healthcare professionals in the Republic of Ireland. Others will tell you that even before the pandemic struck, the health service in Northern Ireland was operating at high capacity with steadily increasing waiting lists for the elective care that Professor McBride referred to as being turned off in response to the pandemic. In this context, we anticipate that the then Northern Ireland Minister of Health, Robin Swan, MP, will repeat his evidence that, quote, underfunding and persistent single-year budgets saw healthcare in Northern Ireland surviving hand to mouth, with a limited ability to plan strategically and deliver better services, and which inevitably had an adverse effect on the readiness of public services to prepare for a whole system emergency. Now, Altnagalvin is the only one of the 40 or so hospitals in Northern Ireland about which you will hear live evidence. But you will no doubt consider the entirety of the written materials available to you on the extent to which the healthcare system in Northern Ireland was and is sufficiently resourced. You will consider, for example, whether, as an official report concluded, one of the reasons that Altnagalvin had the lowest number of nosocomial infections in the region was because they could provide greater single-room occupancy as a result of pre-pandemic funding, fortuitously enabling the opening of a new wing in the spring of 2020 as the pandemic struck. But other sites in Northern Ireland were not so fortunate. Old and poorly ventilated hospital buildings, wards filled to capacity, and staff shortages meant that for far too many of our families, the environments which ought to have nursed them back to health became the places of greatest risk to them. My lady, of course, we recognise that difficult decisions about who to call to give evidence have had to be made, so this inquiry can produce a report at a time when its recommendations will still have relevance. But the personal experiences of the many people I represent, certainly too many to tell every story or even name now, in the absence of a Northern Ireland equivalent witness, are to some extent reflected in what a London-based doctor, from whom you will hear in a week or so, Dr. Tilakumar, described as the disorganised nature of the initial emergency monitoring and isolation of patients, the confused decisions that were made in relation to what infection prevention measures or staff personal protective equipment were required, and the heartbreaking experiences of patients acutely or terminally ill because of a pandemic for which we were ill prepared. Take Samuel Patterson, who was admitted to hospital in Belfast on the 25th of March 2020. He was 75, frail and totally dependent on care from others. When his family contacted the GP about repeated recent episodes of falling, they were told that the GP was not attending homes and that he was probably suffering from a UTI or mini stroke. When an ambulance came to collect Sam, they were told that the local hospital would not accept him, simply because he had a temperature, and so he was diverted to the recently redesignated COVID unit at the Mater Hospital. His family's concerns about this decision were obvious. They were also borne out by subsequent events. Samuel was fine for the first couple of days, but then, for the first time, tested positive for COVID while in hospital. The family were told that Samuel was not a candidate for a ventilator. On the Sunday, the hospital advised that his oxygen levels were down and he was struggling for breath. On the Monday and Tuesday, they were told he had deteriorated further. And despite this, only one family member was allowed to see Samuel. And even then, the hospital thought it appropriate to emphasise the high risk on the ward, the need to remove PPE personally, and the fact that any attendee would be quarantined after the visit. At 11 a.m. the next day, on the Wednesday, the family were allowed a short phone call with Samuel, during which they told him how much they loved him, and he, even though he wasn't characteristically someone who showed his emotions, replied, "I know." Family were told that Samuel would be sedated to make him more comfortable, only to discover later that day that he had died, with only a nurse present, leaving them to contemplate horrendous questions, such as why was Samuel placed on a COVID ward in the first place, and had the hospital unilaterally imposed what the family described as a DNR, perhaps because of Samuel's age or disability. My lady, as Sir Michael McBride observed, the damage COVID wreaked was not just to individuals and families and loved ones. The whole Northern Irish health care system continues to feel the aftershocks of its consequences. In addition to the written statistical evidence available to the inquiry, the same press reports which announced the recent remarks I quoted of the Northern Ireland Director of the Royal College of Surgeons also reported that in June of this year, available figures from the Department of Health show that Northern Irish waiting lists for people waiting for a first consultant-led outpatient appointment across just 4 of its 5 trust areas now total 340,000. 340,000 in a population of 1.8 million, around 1 in 5. And more than half of those patients have been waiting for more than 1 year. It is, quite frankly, obscene. Finally, Sir Michael has told this inquiry that it is incumbent on all that we use the opportunity of this inquiry to learn those lessons of what happened, hear the experience of those most directly affected, and to ensure we are as prepared as we can be for the next, because there will be a next, pandemic. On behalf of all of those who died or lost loved ones in Northern Ireland, we will do all we can within the confines of this module to help the inquiry achieve that aim. And in doing so, we echo the call of the United Kingdom Campaign Bereaved Families for Justice, that this inquiry must not shy away from reflecting the fundamental reality that increased funding of the healthcare system in Northern Ireland will be required to ensure that it not only meets the needs of the next pandemic, but meets the needs of its citizens in the here and now. Lady, thank you very much.
Thank you, Mr Wilcock. Mr Weatherby.
My lady. Dr. Salia Arsan is a member of the Royal College of Emergency Medicine EPRR Committee, Emergency Preparedness, Response and Resilience. She's an emergency medicine doctor and an academic researcher at the University of Cambridge. In February 2020, Dr. Arsan undertook a PHE-related medical role at Heathrow Airport, dealing with travellers who arrived with COVID-type symptoms. But her primary role was in critical care in a hospital in North Wales, where she subsequently managed patients with COVID on ITU and HDU wards. In addition to her practice, Dr. Arsan is an accomplished filmmaker and has made a number of documentaries and programmes for Channel 4 and the BBC concerning healthcare and the pandemic from her own experience. Dr. Arsan is also one of the family members I represent, as sadly her father, Arsan ul Haq Chowdhury, succumbed to the virus in December 2020. She will be the last witness you hear from in Module 3 as the group witness for COVID Bereaved Families for Justice UK, which, as you know, is the group that represents 7,000 family members spread across the 4 jurisdictions of the United Kingdom. Dr. Arsan has 5 siblings, 4 of whom are doctors, all of whom had worked at the hospital where her father died, and 1 pharmacist. Dr. Arsan is therefore particularly well placed to assist you with many aspects of healthcare and COVID as a bereaved daughter and a frontline NHS medic. In the course of her evidence, Dr. Arsan will tell you that her sister had a senior clinical position at the hospital where her father was, and that it was, quote, overwhelmed by COVID. She'll also tell you that the ITU consultant responsible for her father candidly explained that he could not be admitted to critical care or HDU because there were no available beds. And indeed, that was the picture for much younger patients too. This was a capacity and not a clinical decision, a point that chimes with comments made by Ms Carey earlier. A very different picture painted by Boris Johnson, Matt Hancock and others who have brazenly asserted that one of the key successes of the COVID response was that the NHS was never overwhelmed. True enough, we did not see scenes from a dystopian disaster film with empty, ransacked hospitals, but the fact that hospitals and healthcare facilities continue to operate at some level must not be allowed to point to a dangerously misleading conclusion that things went reasonably well. Where acute demand for emergency and critical care services outstripped supply, those services were indeed overwhelmed and unable to function as they should. This is not a metric measured in missed targets. It's not a matter of semantics. Overwhelmed services cost lives. We have no doubt that you'll want to honour the hundreds of thousands of healthcare workers who valiantly and selflessly put themselves on the line to care for all those ill and dying. We do too, not least because we represent healthcare workers themselves bereaved, and bereaved families of many healthcare workers who died. But their efforts, their sacrifice, must not become a cloak for the austerity and underfunding and lack of planning which put them in such an untenable position. The families do not want to clap for healthcare workers. They want their services properly funded, and they want proper staffing levels and bed capacity before it's too late for the next time. I started with a simple example of lack of critical care capacity. But in fact, as you've heard, the evidence of overwhelmed healthcare services started well before hospital care. The government messaging from the outset, advising people to stay at home and to seek medical help only if really necessary, the strength of which, according to not me, but from the Healthcare Safety Investigation Branch, is said to have put off many of those who really needed healthcare. As you heard this morning, that the inquiry's own primary care experts will give evidence that there was little, if any, pandemic planning in GP services and health services at all. There was a funding crisis, too few primary care doctors and healthcare staff, and a consequent retention problem. In earlier submissions, we've referred to evidence from family members of their experience of the 111 services. Rivka Gottlieb has told of the extreme difficulty in her father getting through to the service at all. And even when successful, the advice was to remain at home. Only when, having taken advice from a doctor friend, were they able to express the symptoms in such a way to trigger a response, did they get a paramedic attendance, immediately determining that her father needed hospitalisation. Admitted too late, he unfortunately died in hospital. Likewise, Mary Rogan, who asked for an ambulance for her 52-year-old husband, who had severe and classic COVID symptoms, but which was refused because his temperature had not reached a particular benchmark. He died at home. James Yates, who lived in Scotland, again told to remain home despite serious symptoms and relevant comorbidities. He succumbed too. According to the HSIB, there was a general problem with no questions being asked and no regard paid to pre-existing conditions by 111 algorithms. And distressing though these individual accounts are, inquiry will want to look to whether they are just isolated examples or whether they're more general problems. In that regard, can I add two details to the ones you heard about earlier? And firstly, the HSIB found that in March 2020, only 50% of 111 calls were answered at all. Secondly, there's evidence of further problems in those that were answered in passing them on to expert clinical advisors. So no surprise then that the inquiry expert Professor Snooks has concluded that both of those services, 111 and 999, were at times overwhelmed. She also says that existing inequalities may have been exacerbated. In that vein, we've examples of where it appears that algorithmic questioning failed to take account of racial characteristics. You already heard about oximeters. But Lobby Akinwala's father sought assistance from the 111 service. He was asked whether his lips had turned blue, a question which might well have been appropriate for a white person. Were services such as 111 equipped to deal with patients from different backgrounds, or was there institutional racism which led to the failure to consider the needs of large sections of our communities? Patrick McManus had multiple sclerosis. He was an NHS deputy ward manager, honoured in February 2020 by the city of Derry and Strabane for services to nursing. Weeks after, he contracted COVID and sent home from work. His condition worsened, but the 111 service told him that he could leave the house simply because he'd passed a 7-day marker, presumably acting on an algorithm. Subsequently taken into hospital, a DNA CPR put on his record, apparently without consultation, and sadly he died. From telephone services to ambulances, when patient care progressed beyond telephone advice during March 2020, as you've heard, a protocol was activated for ambulance services whereby those who merited a Category 1 urgent response would be treated as Category 2. It appears that the times for expected ambulance arrivals were vastly increased at peak COVID times. The evidence disclosed so far suggests that in March 2020, the average arrival times for Category 2 ambulance dispatches in London, I repeat, the average time, was well over 3 times the normal standard. Evidence from our families resonates on this issue. Sarah Chowdhury waited 12 hours for an ambulance for her mother. She sadly died 2 days later. When paramedics attended on Dr. Christina Fulop, they declined to take her to hospital because they stated that earlier they'd waited 7 hours outside a hospital with a frail elderly person, and Dr. Fulop died at home the next day. Whether this evidence of overwhelmed services was simply because of the extreme seriousness of COVID, or whether overwhelmed services were a result of no proper planning, no adequate resilience, chronic underfunding, austerity, is a matter for you. But either way, the narrative that the health services coped without becoming overwhelmed is a false one and needs to be called out as such. Pretending nothing is wrong means nothing changes. From ambulances to hospitals, critical care bed capacity referred to earlier. But we already heard evidence in earlier modules that the UK had the lowest number of doctors and nurses per capita than any other comparable OECD country. Bed capacity regularly a problem even with seasonal flu spikes. The evidence suggests that there were real problems with the physical estate, as we heard earlier, about ventilation systems in particular. In each area the inquiry delves into, we urge it to consider carefully the level of planning. We anticipate it'll find precious little beyond the 2011 flu plan. And if that's right, it's a shocking dereliction of duty by those responsible over many years. I note what's been said about DNA CPRs. No less than 422 of our families have raised with us issues relating to DNA CPR. The concerns relate to a range of matters, but the sheer volume indicates serious problems with this part of the system. Were there proper plans in place for consultation with patients and their loved ones? Many of our families report that records indicate there were family consultations when they had not in fact occurred. Was there inappropriate use of DNA CPR as a means of managing or prioritising care capacity despite its real purpose? As Ms Carey told you, that inappropriate and unacceptable DNA CPRs were made at the start of the pandemic was an early finding of the CQC. There's evidence, as you've heard, that a triage tool was developed, essentially a policy to determine who would and would not get scarce care resources and who would not, perhaps on the basis of age or underlying conditions, even disability. But the evidence also suggests that this approach was abandoned and there was in fact, no such formal policy established. But did this leave hard-pressed clinicians and hospital managers in an invidious position of choosing who got admitted to ITU, whether critical care was provided at all, simply because there weren't available beds or equipment or doctors? These are uncomfortable issues and ones the inquiry must address.
Fred, I must ask you to bring it to a close, Mr Weatherby. I'm sorry.
I'll leave it there.
Oh, I mean, to carry on for a sentence or two.
Well, I've got about 90 seconds left, I think.
Carry on.
Tomorrow you'll hear from John Sullivan about his 56-year-old daughter, Susan. He raises a number of highly disturbing issues. He relates serious delay in an ambulance arriving. Susan's medical records indicate that her Down syndrome was recorded as a reason for the decision not to admit her to ITU. She struggled with tolerating an oxygen mask, yet the learning disability team was apparently not deployed to help her, nor were her family allowed to attend to help, which could have made a critical difference. Again, there's an issue of DNA CPR. Did an overstretched health system discriminate on the basis of her disability because it was overwhelmed? Finally, this. Recent reports in the media this week suggest that too little has changed in healthcare since the pandemic. Despite the shocking loss of life, long COVID, all sorts of other damage, has the narrative that the NHS was not overwhelmed, that the UK did okay, prevented a clamour for proper resourcing and revitalised health services and proper pandemic preparedness and planning. In our submission, if that's so, the central mission of Module 3 must be to redress that fiction before another emergency comes upon us. Those are our submissions.
Thank you very much, Mr Weatherby. Very grateful. Ms Hannett, would you like to take us up to the break?
Thank you, my lady. I appear with Ms Iyengar, Ms Siva Kumaran and Ms Johnson on behalf of the long COVID groups, instructed by Ms Jane Ryan of Bat Murphy Solicitors. The long COVID groups are long COVID kids, long COVID physio, long COVID SOS and long COVID support. They are grassroots advocacy organisations whose members came together in the early days of the pandemic to achieve recognition of long COVID and to obtain the care and support that their members need. Their members suffered and continue to suffer the devastation inflicted by the symptoms of long COVID. My lady, in this module, you will hear evidence from two members of the long COVID groups. First, Nicola Ritchie from Long COVID Physios and Natalie Rogers from Long COVID Support. Both will speak to the devastation that long COVID has wrought on their lives and on the lives of members of their organisations. They describe confusion and uncertainty about what was happening to them, a lack of publicly available information and a lack of concern from general practitioners. They are not alone. Surveys carried out by the long COVID groups document the widespread disbelief that members have faced and the lack of recognition of their symptoms. Even after diagnosis, many have struggled to access suitable care and support. Their experiences are at odds with NHSE's opening statement that treatment for long COVID was an example of what worked. Neither do the long COVID groups recognise in their personal experiences the suggestion from the Welsh Government that programmes and services were developed to respond to the need for rehabilitation services for people who have been affected by COVID-19 from spring 2020. Further, whilst the long COVID groups welcome the Scottish Government's commitment to ensuring that every person with long COVID is supported with access to the care that they need, they note that, as implicitly acknowledged, this does not reflect the current position. The long COVID groups invite the inquiry to investigate why, despite long COVID being foreseeable, noting that SARS and MERS had caused long-term morbidity like that seen with long COVID, there was such a delay in recognising and providing any response to long COVID. Further, they have questions about why they, as patient advocates, had to fight for recognition of their illness and disability and for the provision of services by the healthcare system. The long COVID groups ask the inquiry to recognise that the response to long COVID by the UK healthcare system has been and remains inadequate, and that these inadequacies have led to real and substantial suffering. The United Kingdom cannot effectively prepare for the long-term morbidities of a future as yet unknown pandemic without understanding the deficiencies of the response to long COVID in this pandemic. The COVID-19 pandemic is ongoing. People continue to contract COVID and to develop the long-term disabling symptoms of long COVID. As such, the findings we say should be drawn from the evidence resonate today. The written opening submissions on behalf of the long COVID groups have focused on 10 key areas where the inquiry is invited to make findings of fact to inform strong, instructive recommendations on the current response to long COVID, in addition to a future response to long-term sequelae of a novel virus. In making these brief opening observations on behalf of the long COVID groups, I propose to focus on 6 overarching themes drawn from our written submissions. The first issue, which I've touched on already, is the ongoing impact of long COVID. Those impacts are felt at an individual level on a patient's long-term mental, social, education and financial well-being. Adults are unable to work and earn an income. Long COVID has deprived children and young people of ordinary aspects of childhood, such as attending school or playing with their friends. Further, the UK healthcare system itself feels the adverse effect of long COVID, as resources must be allocated to its diagnosis, care and support. Long COVID places an unquantified indirect impact on healthcare system itself due to the disproportionate effect of long COVID on the ability of healthcare workers to carry out their jobs. Further still, the prevalence of long COVID, the most recent statistics saying that long COVID affects 2 million adults and children, as already indicated by Senior Counsel to the inquiry this morning, means that it has a wider financial cost borne by the national economy. Second, the understanding of long COVID has been and continues to be impeded by delayed and then inadequate and now abandoned data gathering and research on both the prevalence and degree of impact of long COVID. There has been no publicly recorded data on the prevalence of long COVID since the ONS winter infection study was closed in March 2024. NHS England cannot feasibly model current and future demand for long COVID services in the absence of any current data on the need for such services. Research into long COVID has been insufficient and delayed, with consequential adverse effects on clinical care. Third, despite it being foreseeable, the healthcare system overlooked long COVID in adults and children. The failure to plan for the long-term effects led to inequalities of access to long COVID services across and within the four nations, as each country adopted haphazard responses which did not address the complex multi-system nature of long COVID. The long COVID groups have set out at paragraph 23 of their written submissions those factors that should inform the provision of assessment, care and support services for long COVID. Much of the current provision is inadequate, variable in its quality, and overall can be assessed to fall a long way short of those criteria. Long COVID in children and young people has been and continues to be an inconvenient truth. The reluctance to accept that COVID-19 could have a more profound effect on some children led to even greater delays in recognising, diagnosing and responding to long COVID in children and young people. When finally established in England, dedicated children and young person long COVID hubs were sparse. Such dedicated clinics in Wales, Scotland and Northern Ireland were either absent or too slow to be established. Fourth, the healthcare system has not committed even now to preventing long COVID. There is no treatment for long COVID. The only way to avoid contracting it is to prevent COVID-19 infections. And yet practitioners, patients and the public were not and are not adequately warned about the risk of long COVID. Further, there was no communication of the risk of long COVID as part of the drive to encourage vaccine take-up. Fifth, long COVID exacerbates pre-existing inequalities whilst creating further health inequalities. Those inequalities relate to socioeconomic status, sex, ethnicity and disability. The inadequacies of data limit the ability to understand both aspects of health inequalities related to long COVID. What can be observed, however, is that there continues to be unwarranted geographical variation in access to services, and the most deprived areas are significantly underserved. Finally, sixth, COVID-19 and long COVID affected healthcare workers disproportionately, yet the occupational protections offered were wholly inadequate. Healthcare workers were not offered adequate respiratory protective equipment. The guidance on infection prevention and control measures and PPE guidance was and remains inadequate for preventing the transmission of COVID-19. Healthcare employers failed to discharge their statutory duties under the COSH regulations. Employers did not always undertake risk assessments to safeguard healthcare workers or employees from the risk of occupational exposure to COVID-19. This had the knock-on effect of employers failing to monitor and conduct ongoing health surveillance of the risks of the virus. The disproportionate impact of long COVID on healthcare workers was not accurately captured in either READOR reporting or any other systematic data collection. For example, as of October 2023, the Health and Safety Executive report that only 36 READOR reports relating to long COVID across all sectors have been received. My lady, the long COVID groups look forward to assisting the inquiry with its important work in Module 3. Those are the submissions on their behalf.
Thank you very much indeed, Ms Hennett. I'm very grateful. We shall break now and I shall return at 3:25. I would like to get as far as Mr Thomas this afternoon if we can. I doubt, Ms Sengupta, if we're going to get to you wherever you are waiting patiently, but we'll get through what we can. Thank you. All rise. Right, it's Mr Wolfe. Oh, there you are. Thank you to those of you who have managed to make sure you're in my eye line, otherwise it gets quite difficult.
Good afternoon, my lady. I lead a team which speaks on behalf of John's campaign.
Are you on the microphone, Mr Wolfe?
Am I on the microphone? Thank you. Apologies. I lead a team, I'm a lady which speaks for John's campaign, Care Rights UK and the Patients Association. Between them, these organisations have a significant understanding of how patients experienced healthcare provision during the pandemic. From its surveys and helpline, the Patients Association can take an overview of the issues faced by all users of NHS services. Meanwhile, Care Rights UK and John's campaign focus particularly, but not exclusively, on those patients rendered additionally vulnerable by disability, especially cognitive impairments, by age or by complex and rare conditions. Just pausing on one particular cognitive impairment, pre-pandemic, 1 in 4 hospital patients was a dementia patient. Those dementia patients greatly suffered through that additional factor. We also have particular concern, my lady, for people whose first language is not English, for people suffering mental health conditions, and for those already approaching the end-of-life period. These were all people whose characteristics should have entitled them to individual consideration under the law, but their human needs and individual choices were often disregarded. They were not always protected from harm. They were placed at a significant disadvantage compared to the rest of the population. In far too many cases, their existing conditions actually worsened, sometimes to the point of hastening their deaths. We also speak, my lady, for the forgotten section of the healthcare system, the unpaid family carers whose value to the economy has been calculated to outweigh the entire NHS budget. Their value to the individuals who support it, and in supporting professional carers, is inestimable. The single and persistent failure to understand their importance was deeply damaging and entirely avoidable. During the pandemic period, all three of our organisations helped to support people denied treatment by including policies of separation, by isolation and other non-pharmaceutical interventions. We also undertook surveys, collected first-hand experiences and tried to make those in authority aware of the consequences of their decisions. For instance, we shared Rachel's experience. Rachel is a former nurse. Her brother suffered from depression and was taken to hospital after an overdose. Rachel explained how visiting restrictions during the pandemic prevented her from supporting him in hospital. She said this: "When in A&E, Chris was still saying he wanted to die. We asked if one of us could stay with him to be his voice, but this was dismissed due to COVID. He said he didn't trust himself to be left alone. Yet despite requesting admission to a psychiatric hospital, he was discharged with no follow-up care and no communication with his family. He died by suicide in February 2021. We also shared Claire's experience. Claire's father, Bruce, had Parkinson's and was admitted to hospital following a serious fall. Claire was his registered carer and was initially able to be with him every day, continuing her care, particularly focusing on his Parkinson's needs. He was recovering well, though very confused. When he contacted COVID, he was moved to a different ward. Claire was forbidden to visit, despite the fact she'd recently had COVID herself and had the vaccinations. His Parkinson's treatment came to an end because the nurses had no time and she was not there to support them. His COVID infection passed, but his overall decline was rapid and irreversible. His official cause of death was pneumonia. Claire says that I fear that the sudden and dramatic separation from us caused him distress and despair, potentially resulted in him giving up hope of recovering. She spoke of her own distress and added, "I feel that my father should have had a right to our loving presence and care during the last weeks of his life. If I had been given permission to wear PPE and care for him in the isolation ward, the risk to me would have been minimal and it would have been greatly outweighed by the benefit to my father and to all of us." Against that background, we draw the inquiry attention to some broad themes. Theme 1, access to basic healthcare during the pandemic was restricted across the whole range of settings. Theme 2, there were widespread problems with communication in healthcare at every level that affected both access to healthcare and its quality. Theme 3, the role of family and friends in healthcare was not well understood and was severely disrupted with discernible adverse effects and irreversible damage. Theme 4, care staff didn't always have training to undertake healthcare tasks when professional health carers would not visit. Finally, Theme 5, people with disabilities and complex conditions suffered the most severe restrictions and were given the least support. Milady, in our written submissions, we describe our concerns about the exclusion of people living in care homes from the mainstream healthcare system. We describe our concerns about inappropriate and occasionally coercive DNA CPR directives. We describe our concerns about poor quality arrangements for end-of-life support and family access. And we describe our concerns about conflicting and inconsistent regulations and the damage done through over-hasting of hospitals without care and testing. All of those things were obvious and foreseeable consequences of the restrictions introduced to address the pandemic. But the government failed to take steps to mitigate them or to communicate how patients' rights and access to essential healthcare should be protected, consistent with the need for infection control. Turning then to the inquiry process itself, our written submission also explains how proper analysis of the impact of the pandemic on healthcare systems will require the inquiry to take specific account of the broad range of settings in which individuals receive healthcare, from their own homes to hospitals to care homes and other residential healthcare settings. The inquiry will also need to scrutinise the intense focus during the pandemic on infection control at the expense of many other healthcare issues. And so we would like the inquiry particularly bear in mind the following things. Firstly, healthcare is not just delivered by medical professionals in hospital settings. Secondly, the failure to treat family carers as part of a healthcare team damaged the quality of and access to healthcare for individuals who relied on family carers to advocate for them, interpret their needs and ensure they received the healthcare they needed. And of course, it also made the job of the professional carers harder. The decision to discharge patients from hospital into residential care settings without testing for COVID-19 had a devastating impact on individuals who live in those settings. Next, guidance and regulations across the UK was often conflicting, confusing, and lacking in clarity. Clear guidance would have obviated some of the harm caused to vulnerable groups. Next, there were serious issues with the provision of palliative and end-of-life care. Next, human rights of individuals and the need for individualised assessments more rather than less important in times of crisis. Can we then give some thoughts on what we say needs to happen? First, the NHS must ensure that patients receive a comprehensive service even in times of crisis. Second, we must focus on protecting the people most at risk, not on protecting institutions. Third, lives must not be devalued in times of crisis. Fourth, systems must be in place to safeguard rights and ensure that the voices of people using services are always heard. Fifth, essential caregivers, including family members and friends, must be treated as key workers. Sixth, the right to family life must be respected by all those in all settings with duties under the Human Rights Act. Seventh, consent is and must remain a key aspect of the provision of healthcare. Particular attention must be given to the needs of people with protected characteristics and those approaching the end of life. Eighth, respect for individual dignity and responsibility should always be maintained. Infection control should not override personal consent. I'd like to come towards the end by sharing the experience of Pam, if I may. She wrote about her daughter Jen, who died at the age of 38. Jen had a complex medical condition, which meant she lived at home with both of her parents for most of her life. When she was admitted to hospital pre-pandemic, her parents would continue to accompany her, continuing and providing her complex and specialist care alongside the professionals. At the beginning of the pandemic, they were given a letter from the hospital CEO to say that this arrangement should not only continue, but was essential. However, that letter was then not accepted by the ward. Jen, separated from her parents, wrote to the CEO saying she didn't feel safe. She never got a reply. Her mother describes how she felt when she watched her daughter, via FaceTime, struggling and uncared for. Every day I was phoning up to ask if I could go and look after Jen. Every day I was given a different reason why not, mostly centred on PPE. I was told that Gold Command and later Silver Command were making the decisions. I asked if I could come in and discuss it with them. I was told by the matron that if I came to the hospital, security would be called. Jen's condition worsened. She said she wanted to kill herself. No one understood what was happening to her. Even when she'd suffered a series of epileptic fits, her parents were denied access. This was on the grounds of reducing footfall and a lack of PPE. Pam offered to pay for PPE. She offered to pay for Jen to have a nurse, but she was told there weren't enough staff. Jen and her parents were told that the ICU would not accept her. A DNR notice was forced on them. On the 21st of January 2021, the consultant said that Jen would die during that day. Her parents were finally told they could have an hour with her and could split it if they liked. The 30 minutes in the morning went well, but by the time they called back in the afternoon, their daughter was dead. My lady, finally, perhaps the most difficult question before this inquiry is what caused some people during the pandemic to behave in that way, and how the basic rights of patients and their families might be better protected in future. Thank you, my lady.
Thank you very much, Mr. Wolfe. Mr. Wyden, I think you're hiding over that side today.
No longer hiding. Thank you and good afternoon. I act for the Pregnancy, Baby and Parent Organisations, or the PBPOs for short. I also act for the Clinically Vulnerable Families, and I am assisted by Daniela Wadup and Rosa Palaschek. We're instructed by Kim Harrison and Shane Smith of Slater and Gordon. I begin with the PBPOs. The group brings together 13 organisations working in early pregnancy, maternity, antenatal, neonatal and postnatal care. Aching Arms, Baby Lifeline, Bliss, the Ectopic Pregnancy Trust, Group B Strep Support, ICP Support, the Lullaby Trust, the Miscarriage Association, National Childbirth Trust or NCT, Pelvic Partnership, Pregnancy Sickness Support, Tommy's and the Twins Trust. One message from their collective experience is clear. The reactive healthcare response to COVID-19 failed to properly value the care of women, pregnant people and newborn babies, and failed the women, pregnant people and babies who were supposed to be at the heart of that care. These failures have left many women and pregnant people traumatised. They led to partners and fathers being wrongly excluded from the first hours, days and weeks with their children. They resulted in unbearable choices, such as the parents of neonatal twins who had to choose which parent could visit and divide the 1 hour of allocated visiting time between both children. The mother, who had to call her partner after emergency surgery to explain that both their babies had died and due to poor phone signal, had to decide what to do with the embryo's remains alone. And those who simply lost the ability to choose how, when, where, and with whom they would deliver their babies. These failures were not merely missed opportunities to provide preferable or ideal care. As the Royal College of Obstetricians and Gynecologists has identified, some women received maternity services that were inadequate. Devastatingly, some pregnant women died in potentially avoidable circumstances. These errors appear to have been the result of structural failures to pay attention to, prioritise and provide sufficient resources to the safety of pregnant women and people and their babies. And the failures were not quickly identified nor remedied. Visiting restrictions continue to affect pregnant women and people for prolonged periods, including when public restrictions had eased, and even while the public were being encouraged to eat out to help out. And so did restrictions on parents being able to spend time with their sick newborn babies in neonatal intensive care. Against that background, Chair, our submissions are divided into 4 main themes. First, restrictions on access to services for pregnancy and baby-related care. A major study on maternal deaths and morbidity, Embrace, found that COVID-19 was the leading cause of maternal death in the UK. And this disproportionately affected Black and Asian ethnic minority women. It found that improvements in care may have made a difference in 76% of those maternal deaths from COVID-19. These were failures to ensure adequate care was given to pregnant women and people, amplified by an already under-resourced system in which women and minorities' voices were routinely dismissed. These failures were also not merely a result of an inevitable struggle to respond to a novel virus. The study found that clear guidance was either not known about or not applied. Chair, the PBPOs invite the inquiry to investigate whether the lack of attention and prioritisation of maternity and related services was indicative of structural failures to recognise the importance of continued care for women, pregnant people and children. Staff shortages also had a major impact on the provision of services, and notably on the choices pregnant women and people could make about where and how to give birth. As early as the 23rd of March 2020, the day that lockdown was announced, the Chief Nursing Officer from England was informed that London Ambulance Services had advised it could no longer guarantee ambulances would be available to attend to home births or a woman giving birth in a standalone birth centre if an obstetric emergency occurred. She was also informed that epidurals might not be available if anaesthetists were required to attend to COVID-19 patients. In April 2020, 57% of home birth services were closed in England. In late November 2020, 24 NHS trusts across England were reporting that COVID-19 was impacting on the maintenance of safe staffing levels in maternity services, and this did not improve in the second wave of the pandemic. For ectopic pregnancies, access to non-surgical treatments and to laparoscopic surgery was reduced due to COVID-19 related restrictions. And that meant some women were forced to have more invasive procedures than they would have wanted if they had the choice. Another major impact of COVID-19 was the limited ability to provide face-to-face care, particularly in the community, including once people were discharged home. There was reduced access to midwives and health visitors, exacerbated by the absence of contact with direct family due to the lockdown restrictions. This left many new mothers and families isolated. Without either face-to-face support from specialists or from friends and family, women and their partners could not access effective bereavement care. We submit the inquiry should treat bereavement and postnatal support as a crucial form of pregnancy-related healthcare provision. The PBPOs have submitted evidence which shows that women and pregnant people express consistent fear of COVID-19 and that this discouraged some who ought to have sought early pregnancy or maternity care. We request, Chair, that the inquiry investigates how information was communicated during the course of the pandemic and how this contributed to confusion and misunderstanding of how pregnant women should engage and seek care. Our second theme is visitor restrictions. or another way of putting it, preventing pregnant women, people and babies from receiving essential support. Infection prevention and control, or IPC measures, were a necessary part of promoting safety in healthcare settings. But decisions to impose restrictions on visitation and support caused disruption and distress to pregnant women, pregnant people, babies and their families. It was eventually recognised across the UK in various iterations of visiting guidance that birthing partners are an essential part of the caregiving team for the pregnant women or birthing people. The PBPOs remain concerned, however, that visiting restrictions were imposed without sufficient care and without appropriate weight being afforded to the harms caused by isolating women and birthing people and all their babies. By 16th of July 2020, only 19% of units allowed partners to attend antenatal scans. And although 97% of units were allowing partners to attend births, that is a slightly misleading statistic, because half of those units only allowed partners in once active labour was confirmed. How individual trusts applied that was inconsistent. One result was that some women and pregnant people felt coerced into vaginal examinations to determine if labour was sufficiently established, so that their partners could finally enter the room. Other women's care suffered because they had no family or support people available to them to help to understand what was being said by staff. The Health Services Safety Investigations Body reports a rise in stillbirths during COVID-19 and identified that around 43% of the birth incidents they investigated involved a mother who did not speak English as their first language. The PBPOs submit that the inquiry should closely scrutinise decision-makers' understanding of the IPC risks in early pregnancy, maternity and neonatal care, the proportionality of the restrictions imposed, and, centrally, the impacts of those restrictions. Could alternative IPC measures to blanket visiting restrictions been considered and used? And we invite the inquiry to examine the clinical justifications for and proportionality of the restrictions placed on allowing pregnant women and people a support person during all forms of care. And also the delay until December 2020 in providing national guidance on visiting in maternity services. Our third theme is inequalities in care of pregnant women and babies. The PBPOs are concerned about areas of inequality which emerged in the delivery of early pregnancy, maternity care and neonatal services during the pandemic. And we submit the inquiry should consider the long-term impact on future generations of the inequalities in maternity and neonatal care which were further baked in through the pandemic. Our final and fourth theme is PPE care and contact with babies and impact on families. One woman whose baby was in the neonatal ward said PPE made her feel cut off from her baby. She's 8 weeks old and I haven't kissed her yet. There were extraordinary and upsetting experiences for many parents, and there seems to have been a failure to consider the wider health consequences of imposing blanket rules, such as mask wearing for new parents in the name of general public health, and at the expense of skin-to-skin contact. In conclusion, the PPPOs call for the inquiry to make sure that pregnant women, new parents and infants are not overlooked in future pandemic responses and public emergencies, that inequalities are highlighted, and that the care of pregnant women, pregnant people and newborn babies is properly resourced so that fundamentally they are safe. I'm moving on now to the clinically vulnerable families. CVF is a grassroots organisation born of the pandemic. It represents the clinically vulnerable, the clinically extremely vulnerable, the immunosuppressed and their families. I start with this point, Chair. Some 18 months ago, on the 28th of February last year, you held the first preliminary hearing in this module. As you know, we were not in this hearing room, but in a cavernous function suite in a hotel. After each advocate spoke from the same lectern, and before the next one could begin, a gloved employee painstakingly wiped the lectern down. When I stood up to make my submissions, I held up my client's CO2 monitor, which I have again here, and I asked, on their behalf, what about the air quality? What about ventilation? COVID is airborne. What, I asked, was the inquiry doing to ensure that the air in the hearing centre was well ventilated and cleaned? Over the months that followed, my clients had extensive discussions with the inquiry staff, who, to their credit, have been diligent and accommodating. Air filters, the machine which is behind me, were provided and a CO2 monitor sits on top of it. Why do I start here? To use fashionable language, the inquiry and CVF have been on a journey together. And that journey illustrates the journey which the UK has been on too, towards understanding and accepting that COVID is airborne. It doesn't just exist in large droplets which fall onto surfaces, it floats through the air. COVID is airborne, 3 of the most important words in this inquiry. A number of questions arise. Who knew? When did they know? When should they have known? Those are classic questions for lawyers. But finding out who knew what and where, and who should have known what and when, will not bring back a single life of the over 200,000 that have died, the vast majority of them clinically vulnerable, including many healthcare workers and people who caught COVID-19 in hospitals, which were supposed to be places of safety. A crucial question, we say, is what are the implications of what we know now? Ms Carey this morning referred to the inquiry's important forward-looking perspective. That is music to the ears of CVF. The fact that COVID is airborne is an inconvenient truth because it undermines many of the major messages given out during the pandemic to the public. Hands, face, space. What about air? It undermines much of the guidance, which was the foundation of how patients and healthcare workers were protected, or as it turned out, unprotected. For much of the pandemic, the clinically vulnerable and clinically extremely vulnerable were told if you follow some simple rules, you'll be protected. You will be shielded. But as the evidence in this module will show, there was a paradox. The people who were given the strictest precautionary advice at home were the same people who were most likely to have to spend time at GP practices and in hospitals. And there, they were exposed to a serious risk of contracting COVID-19. The clinically vulnerable were told to take personal responsibility, wash their hands and keep their distance. But by focusing on personal responsibility, public authorities may, at the same time, have been washing their hands of their own responsibility. Patients cannot be responsible for the environments in healthcare settings. Institutions are responsible for those environments. The realisation that COVID-19 is airborne requires a paradigm shift in our understanding of how to protect everyone from the virus and any airborne pathogen, including the flu. We need better ventilation, air filters, high-quality masks. Good ventilation is key, as Ms Carey said this morning. In one sense, the pandemic has been the greatest ever missed opportunity to educate the public on those simple mitigations. Improving air quality would be the simplest improvement in infection prevention and control since hand washing. Improving conditions for the clinically vulnerable means improving conditions for all. We trust, Chair, that now you have such high quality and conclusive evidence, not just me holding up an air monitor, for example, from Professor Beggs, that your inquiry will not squander the same opportunity. Or we will be back to square one now and when the next pandemic hits. And against that background, I'll briefly summarise some key points we make in our written submissions. First, the decision-making process used to identify the clinically vulnerable. CVF accepts that, to an extent, an iterative process was unavoidable. Clinical criteria for shielding was adapted as more evidence about the nature of the disease emerged. But this does not explain some key omissions. For example, why were learning disabled adults not added to the shielded patients list until the 19th of February 2021, despite evidence being published in November of 2020 that people with learning disabilities were 3.6 times more likely to die from COVID-19? Inconsistencies and delays meant some very vulnerable people were unaware of the need to shield, and those who were clinically vulnerable, as opposed to clinically extremely vulnerable, were not actively contacted or informed of their risk status until they were called for their first vaccines in 2021. Clinically vulnerable people were not advised to shield, nor were they offered protections such as entitlement to sick pay or priority access to essential medications and food. Unless individuals had educated themselves, they were left unaware of their increased risk, and we asked the inquiry to investigate the factors which led to the distinction of these two groups. A second focus, the decision-making process used to decide when to start, pause and stop the shielding programme. CVF submits the shielding programme began too late, meaning too many vulnerable people were put at unjustified risk. CVF also has serious concerns about the abruptness with which the shielding programme ended. In CVF's factual evidence from Dr. Catherine Finnis, which reflects many members' concerns, she describes stopping shielding as like falling off a cliff. When national shielding advice and associated support came to an end on the 31st of March 2021, around 30% of the 3.8 million people in the shielding list had still not received a first dose of the vaccine. And for some clinically extremely vulnerable people, the vaccine was not particularly effective for them in any event. Chair, we invite you to investigate whether the shielding programme should have ended at that stage and whether transitional or rehabilitative support after the end of the shielding programme was fit for purpose. Third, communication and advice for people shielding and designated as clinically vulnerable. People shielding and those designated as clinically vulnerable and at the highest risk had the right to expect timely, evidence-based and sensitive communications and advice. Yet they frequently felt as if they'd been forgotten or as if their needs and concerns did not matter. On a most basic level, vital communications, such as those advising people to shield, did not always reach the right people or reach them in good time. And we invite you to scrutinise, Chair, the underlying reasons for these problems, the effect of which has been to leave clinically vulnerable people exposed, unsafe, and as a result of widespread public misunderstanding, at a risk of discrimination and abuse. Fourth, the impacts of the shielding programme. Shielding undoubtedly protected some of the most vulnerable, but it also had negative psychological and social effects, as well as practical limitations. There were mental health impacts, impacts on family and household members of those shielding, restrictions on receiving care at home, financial implications, many of who shielded lost businesses and jobs, and more broadly, social isolation and stigma. CVF requests that the inquiry investigates whether these impacts could have been mitigated by support that was targeted, meaningful, and more long-term. Fifth, access to healthcare for people shielding and for the clinically vulnerable. As a result of the failure to implement basic protective measures across healthcare, many clinically vulnerable people have felt and continue to feel that they cannot access healthcare safely. Two issues are of particular importance: the lack of clean air and adequate ventilation, and the lack of evidence-based guidance in relation to face masks. CVF submits that both of these shortcomings have contributed to an avoidably high level of hospital-acquired infection, which have put vulnerable people at particular high risk. And I say again, hospitals are supposed to be safe places, not places where you contract further illnesses. And CVF invites the inquiry to conclude that meaningful and urgent changes are needed to ensure the air in healthcare settings is clean and safe to breathe. And we also ask you to investigate the difficulties many clinically vulnerable people have experienced in accessing their usual care for their underlying conditions. Sixth, decision-making about healthcare provided to COVID patients. CVF considered there should be an urgent systemic review of DNA CPRs put in place during the height of the pandemic. And also support should be put in place for those affected by decisions forced on them. And finally, decision support tools. CVF remains concerned about the longer-term impact of pandemic conversations around clinical prioritisation and the use or the putative use of scoring systems. CVF welcomes the inquiry's scrutiny of this issue and hopes this will bring clarity as to the design of the proposed prioritisation framework by the working group in late March 2020, as well as the Department of Health's decision not to continue with this work. To conclude, CVF's concerns are linked by a common theme: the inescapable reality that the disproportionately severe impact of COVID-19 on the clinically vulnerable and associated decision-making were insufficiently considered and mitigated since the emergence of COVID-19. The clinically vulnerable continue to feel the effects and live in the shadow of the virus today. Thank you.
Thank you very much, Mr Wagner. Very grateful. Ms Moynihan, I think you're going next.
Good afternoon, my lady. My lady, I appear on behalf of the Department of Health in Northern Ireland, which I refer to as the Department. The Department wishes again to take the opportunity in this module to extend its condolences to those who lost loved ones during the COVID pandemic. Those who were lost and those who mourn must and will be at the forefront of our minds as we assess the impact of the pandemic on our healthcare systems, healthcare workers and wider society. We must also not forget the efforts of all of those who worked tirelessly across the front line of healthcare organisations to provide care and support to those sick and dying, working both compassionately and professionally throughout. We remember also those who are still living with the effects of COVID-19. Through the condition that has become known as long COVID, there are also people who continue to be affected by the measures introduced during the pandemic to protect people, to protect the healthcare systems and society at large. The Department acknowledges that the interventions in response to the COVID-19 threat, whilst necessary, had serious consequences for many parts of society. The Department has said previously that the challenge was not to make the right decision, but rather to make the decision that was least wrong. In reaching the least wrong decisions, the Department was acutely aware that those decisions would have ongoing repercussions on the healthcare system, on those working in it and those who required its services. Shielding, for example, was introduced in Northern Ireland with the aim of protecting the most vulnerable in our society. And as our former Health Minister, Mr Robin Swan, stated in his witness statement to this module, the need for shielding was kept under continuous review. The significant impact that shielding had, both in terms of loneliness, isolation and the deleterious impact on mental health, was shown by the findings of the Patient and Client Counsel survey. These findings indicated that shielding resulted in a detrimental social and psychological effect on a significant group of those who responded to that survey. It was in light of those findings, once shielding was paused in Northern Ireland on the 31st of July 2020, that, unlike in England, it was never reintroduced in Northern Ireland. The Department's advice to the Northern Ireland Executive ultimately led to the implementation of various measures in response to the pandemic. This response included shielding, the closure of schools, shops, restaurants and hotels, social distancing and the wearing of masks. Whilst the Department has previously acknowledged that these measures impose a huge cost on society, it remains of the view that the advices given and the decisions taken were the optimum choices at the time, based on the state of knowledge at that time. The Department ensured that these measures were reviewed regularly and were intended to only be as restrictive as was strictly necessary. This module has the benefit of an expert report from Dr. Ji Yin Shin, Professor Dinah Gold and Dr. Ben Warren on infection prevention and control. In respect of visiting guidelines, the learned author's conclusion was that it was unlikely that any iteration of visiting guidance would satisfy all relevant stakeholders, who all have very different priorities and responsibilities. My lady, the Department considers that this is a conclusion which could be drawn in respect of all of the guidelines and measures enacted throughout the pandemic. Visiting guidance applied equally across all healthcare settings, but throughout the pandemic in Northern Ireland, it evolved as knowledge of the virus increased, including transmission rates and community prevalence. The Department was motivated to keep the most restrictive measures in place for as short a period as was possible. The same approach of minimising the restrictions of non-pharmaceutical interventions was mirrored in a more formal way in the Health Protection Coronavirus Restrictions Regulations of 2020. Regulation 2.2 of those regulations required the Department to review the need for restrictions at least once every 21 days. Further, Regulation 2.3 stated that the Department should terminate any restriction as soon as it was considered no longer necessary. The Department considers that it carried out these responsibilities with the utmost of concern and it advised the Northern Ireland Executive in relation to the possibility of relaxing restrictions each time it became apparent, whether from scientific or medical advice and data, that those restrictions were no longer necessary or proportionate. The Department acknowledges that the impact of decisions taken by it and the entire Executive were at times understandably difficult to accept by various stakeholders. However, we consider it is a testament to the people of Northern Ireland that the vast majority of them did rise to this challenge and followed the restrictions in a way that ultimately reduced the overall impact of COVID-19. And for that, my lady, the Department repeats its thanks to everyone for the sacrifices they made, and we confirm that we stand ready to learn from this inquiry's work. Thank you.
Thank you very much. Mr. Pisani, have I pronounced it correctly?
My lady, yes.
I think you need the microphone, though.
Is that working?
That's it. Thank you.
My lady, I make submissions on behalf of Mind, the leading mental health charity in England and Wales. The focus of this module is on, in relation to mental health, children and young person inpatients. But Mind reminds the inquiry that the pandemic had a profound impact on all people struggling with their mental health. One study found that people with serious or severe mental illness were almost 5 times more likely to die during the pandemic than people without severe mental illness. On the 13th of November 2020, the then Chief Executive of Mind issued an urgent communiqué, warning that the nation was in the grip of a mental health emergency. Mind identified the personal trauma this was causing individuals, but also the added strain on the NHS. Mind urged the government to learn from what went wrong in the first wave of COVID-19 and make sure people could get prompt access to the help they needed in order to protect both their mental health and the NHS. Mind's current Chief Executive, Dr. Sarah Hughes, now finds herself making very similar recommendations today, with an emphasis on, first, a need for forward planning for mental health provision in the event of further pandemics. Second, the expansion of community alternatives to inpatient admission. Third, ending the inappropriate out-of-area placement of children and young people and ending their admission to adult wards. Fourth, on an end to the digital exclusion of disadvantaged children and young people from mental health services. Fifth, ensuring children and young people are discharged from hospital only when it is safe to do so, and conversely, that they are not left languishing in hospital due to under-resourced community aftercare. And sixth, for there to be urgent improvements to hospital and community mental health staffing levels, which need to be more consistent and with reduced reliance on agency staff who will be unfamiliar with often very complex cases. The pandemic resulted in an increase in mental health problems for children and young people, leading to increased demand for services to meet that need. Children and young people are at a higher risk of anxiety and depression caused by lockdown. Notably, cases of severe eating disorder in children and young people increased significantly during and beyond the pandemic, with potentially grave consequences. Eating disorders have the highest mortality rate of any mental illness. The pandemic worsened health inequalities within child and adolescent mental health care. At the start of the first lockdown, there was a significant rise in the number of psychiatric admissions to hospital from the most deprived areas of the country. People with protected characteristics all fared disproportionately badly in the deterioration of their mental health during the pandemic, but those who suffered most were those people with pre-existing mental health conditions. In its Not Making the Grade report from 2021, Mind found that during the pandemic, existing inequalities in housing, employment and income had a greater impact on the mental health of people from racialised communities than on white people. The inquiry experts appointed for this aspect of this module, Drs. Northover and Evans, confirmed that there were apparently no specific plans in place for mental health inpatient services in the UK's pandemic preparedness planning, despite the predictable and serious mental health toll of social isolation, anxiety, financial distress and grief. Nor was there consideration of the mental health impact on children and teenagers. for example from disrupted schooling and social isolation. Mind's research has found that children and young people were particularly vulnerable to the impact of the pandemic. They were the most likely to use negative coping mechanisms, with almost a third reporting self-harming to cope with lockdown restrictions, making them more than twice as likely to have coped by self-harming than adults over 25. Young people who were most disadvantaged were also the most likely to face digital exclusion. And children and young people the least likely to feel comfortable with remote mental health support, which doesn't always enable apt privacy or an accurate assessment of an individual's mental health, nor is it always an effective means of providing treatment, and it should thus not represent a panacea response to the need for infection control. The children and young persons mental health sector is staffed by dedicated individuals, many of whom struggled through the pandemic to provide for the vulnerable people in their care. But a part of that struggle was with inadequate resources. In the years before the pandemic hit, children and young people's mental health services had been criticised for their failure to meet the needs of the most vulnerable people in our society. In 2017, Sir James Mumby described the well-known scandal of the disgraceful and utterly shaming lack of proper provision in this country of the clinical, residential and other support services so desperately needed by increasing numbers of children and young people. The surge in demand for mental health care in 2020, along with the restrictions imposed by lockdown, led to a further reduction in the availability of mental health services at a time when they were needed more than ever. Mind's report on the consequences of coronavirus for mental health from 2021, which included insights from over 1,700 young people, found that 18% of them experienced mental distress for the first time during the pandemic. And nearly 90% reported that loneliness caused by the lockdown worsened their mental health. But 42% of those young people had to wait 3 or more months to get support, and over a quarter had to wait more than 4 months. A 2022 CQC report found a 32% rise in the number of under-18s being admitted to adult wards due to lack of alternative inpatient or outreach services, and warned that the impact of the COVID-19 pandemic on children and young people's mental health services continues to be felt, with services struggling to meet rising demand. This is increasing the risks of children and young people ending up in inappropriate environments. Mind continued speaking to people coping with mental health problems throughout the pandemic, and one of the most valuable aspects of Mind's evidence is in those voices. They are not typical, because there is always nuance in an individual's experience of symptoms and treatment. But there are themes, one of which is a tension between infection control and the management of risks arising from mental disorder, with potentially grave consequences. In one case known to Mind, a young person who was a psychiatric inpatient and an acute risk of suicide needed to travel to A&E for suspected self-harm. But she was discharged from the psychiatric hospital and refused readmission there because of the risk of COVID infection. So she went home. And the next day, she ran away from the family home with the intention of jumping off a bridge. Thankfully, she did survive. Another young inpatient reported the effects of isolation on the ward. Quote, "The whole ward had COVID. Everyone alone in room for 2 weeks. Food left outside door. No conversation at all for the duration. Bedroom stripped, so nothing to do. Staff not noticing risk behaviour, e.g. I flushed my food down toilet. Was written down I had eaten, as plate was empty. Didn't drink for 4 days toward end of isolation. Ended up in critical condition as no one knew. 1 day without fluids actually being 5, etc. No physical health monitoring during the 2 weeks. No way to monitor the effects my eating disorder was having on my body." It's vital to recognise that mental disorder can itself cause severe risk to the health and the life of those suffering from it. A child or a young person becomes a psychiatric inpatient when there are significant risks associated with their mental disorder. Mind calls for clear recognition in guidance of the importance of balanced risk assessments, so that the imposition of pandemic control measures does not result in insufficient weight being given to the risks arising from mental disorder. Inpatient services represent one end of a spectrum of treatment strategies that should be available to children and young people when they need them, at the level on that spectrum that they need them. On the other side of the ward doors, adequately resourced community resources and mental health services are a vital part of what should be a cohesive system by which to provide children and young people in mental health crisis with timely intervention. This is the only way to ensure that young patients who have been discharged from inpatient services get the aftercare they need to promote sustained recovery and avoid readmission. And prompt community treatment can prevent deterioration and the need for readmission, thus relieving the pressure on inpatient beds. Society has a duty to our children and young people to ensure that mental health services are prepared for the consequences of the next pandemic. If we fail that duty, we fail a generation that now has unprecedented insight into its own mental health and into the need to seek help. That insight represents societal progress. In May 2022, Mr. Justice MacDonald reminded us that the development of children and young people and the development of society are intrinsically and inseparably linked. If there is a failure to safeguard and promote the welfare of the children and young people, then society as a whole will suffer. Planning for the mental health effects of a pandemic on children and young people and the allocation of resources to a long under-resourced sector is urgently needed. In the event of further pandemics, all mental health services must be prepared for the foreseeable effects on the psychological well-being of the generations that represent our future. Those are the opening submissions of mine.
Thank you very much for your help. Mr. Simlett.
Good afternoon, my lady. The COVID Airborne Transmission Alliance, or CATA, is very pleased to be here in this module and welcomes the inquiry's direction of travel. CATA's helped the inquiry in this module, we would hope, to make important progress with its fundamental points appearing to have been accepted. First, the inquiry has, in the Module 1 report, treated COVID as airborne and examined the planning for airborne viruses. Secondly, as Mr. Wagner has just said, the inquiry's own approach to wiping down the lectern between counsel speaking and so on is no longer occurring. In fact, at one of the earlier preliminary hearings, I was stopped by my instructing solicitor from saying that there was no need to do that because COVID was airborne, because she was concerned it would come across as facetious. Now it's orthodoxy. Thirdly, CATA's commends your calling, CATA's evidence will be, we hope, helpful and important in this inquiry. CATA commends your calling Dr. Barry Jones early on and commends that his detailed and considered and authoritative witness statement is being put to other witnesses. And my lady, this is all very refreshing to CATA compared to how they were treated before. Because as you know, CATA's members are healthcare professionals, but importantly, CATA did not exist prior to the pandemic. CATA and its previous incarnations only came into being because experienced, knowledgeable healthcare professionals could see in real time the terrible errors being made and were compelled to do something about it. Regrettably, the response from those in authority was to ignore or seek to manage their concerns, and they were marginalised. And so it is of a relief to them to see that their concerns are being taken seriously by this inquiry. Now, my lady, some points on healthcare professionals and the misdirection of them during the pandemic. Healthcare professionals are, one, used to taking serious decisions informed by evidence and also knowing and following procedures. Secondly, are people, and in the COVID pandemic, recipients of advice given to the wider public. And thirdly, people with common sense. And one theme in this module is the obvious conflicts between the instructions being given to the wider public to stay apart from other people, minimise interactions, meet only outside or in well-ventilated spaces, when contrasted with the instructions and procedures that CATA could see being provided at work, and indeed what was being said to healthcare workers or what they could see with their own eyes was often obviously contradictory or impossible to implement. Essentially, my lady, knowledgeable healthcare workers were instructed to suspend their common sense and instructed to follow confused and flawed instructions in relation to their working practice and their dealings with patients. They were instructed to trust in procedures that were not scientifically based and without equipment that was obviously necessary. They were told, or they were not told, that these decisions were based on lack of resources or equipment, though we submit that plainly that the evidence will show that to be the reason, and instead were expected to believe that such equipment was not required. Among your 250 witness statements is one from Dr. Natalie McDermott, who's an award-winning infection control expert. She describes different colleagues from different healthcare professions having different kit to deal with the same patients, depending, it seemed, on the approach taken by their professional bodies or the particular level of authority of the medical professional involved, such as senior consultants being able to override things. Those failures, as we submit they are, of infection prevention control often had grave consequences for the clinicians involved. Dr. McDermott herself is now seriously disabled from long COVID and has become a wheelchair user alongside other problems caused by the pandemic. As that statement also says, there have been very considerable problems even properly reporting that sort of injury under the RIDOR regulations, and what we submit is unreasonable disputation of her COVID infection being work-related. There were serious consequences, of course, for patient care. That same statement at paragraph 29 says this: "I have no doubt that the patients on my ward received a lower standard of care as a result of our IPC policy. As staff did not feel adequately protected, they felt reluctant to have physical contact with patients and reluctant to spend the time necessary with patients to carry out the best possible treatment. Staff would also be mentally distracted due to the stress and fear of being infected, which even further eroded the level of care provided to patients." And then she continues with a number of specific examples. You're also calling Tracy Nichols from the College of Paramedics, from whom you'll hear next week. She describes obvious dangers in requiring ambulance personnel to stay in the back of ambulances for extensive periods at hospital. She will tell you about the enduring effects in terms of fear, estrangement, and increased staff turnover even after the pandemic. So what we submit is that the context for this module is that what CATA has consistently been saying is supported by the expert evidence marshalled, that SARS-CoV-1 was known to pose a particular risk to healthcare workers due to the nature and proximity with which they have to work with patients, and that the scandal, for that is what it is that COVID's airborne nature was never properly addressed until it was far too late. Indeed, it may still not be being properly addressed. Even recently signed statements from the state witnesses do not seem to accept that. The response was never about following the science at all. All of this was compromised for economic and pragmatic reasons. And in our written submissions, we've highlighted specific matters to look at in relation to the workings of the IPC cell. And we say that's an important matter for your investigation. It's not currently clear that all of the IPC cell minutes are available, and as we go through, the inquiry will need to scrutinise very carefully the workings of that body, and very robustly. Because it seems to CATA that the IPC cell towed a line born of expedience, particularly political expedience, rather than actually following the science. So the materials disclosed and the evidence you're calling will show, unfortunately, catastrophic failures to protect healthcare workers and their patients, and those still remain today. And those breaches of trust, or to use the words of John in your opening video this morning, the moral injury to the profession, are not just reprehensible in terms of the treatment of committed staff, but also affect service provision. Failures to inform and protect clinicians damage the provision of healthcare to all. My lady, we'd also ask you to keep this in mind. Although this module is looking at healthcare systems, those systems comprise people. An inquiry such as this should also look to hold individuals accountable for what we submit are serious failures. Dangerous practices and those responsible for them must be stopped, and that danger is ongoing. Finally, my lady, as invited by your counsel in her opening, CATA is going to be wanting to make submissions on recommendations, and I'll trail some now because some are of real urgency. First, in concordance with the expert IPC reports, CATA wishes to see immediate changes to IPC guidance reflecting updated aerosol physics and transmission, together with mitigations including respiratory protective equipment and ventilation. This should be UK-wide. Second, a complete overhaul of IPC guidance and governance with new leadership of a multidisciplinary body. And pausing there, my lady, those matters we would submit are of such urgency that you may need to consider making interim recommendations. Thirdly, that all healthcare workers should be protected under health and safety law from airborne pathogens, particularly at close range, and for RIDDOR reporting to be robust. Next, that there needs to be meaningful stakeholder end-user engagement with full transparency and clear accountability to restore healthcare worker trust, and to ensure, in concordance with your recommendation from Module 1, pandemic planning to ensure adequate supplies of respiratory protective equipment. But finally, that the precautionary principle and common sense should always prevail in the face of scientific uncertainty. So, my lady, those are my submissions.
Thank you very much, Mr. Simblett. Mr. Thomas, last but definitely not least.
I hope fatigue has not set in.
Not at all.
My lady, do you remember the video we watched this morning, the impact video? And there was that healthcare worker, I believe she was a doctor, who was saying, we just have to accept the discrimination.
I think she may even be present, or has been present today.
Yeah. Well, on behalf of FEMO, the Federation of Ethnic Minority Healthcare Organisations, we say we don't have to accept it. We just don't. Why? It reminds me of that James Baldwin quote, "Not everything that is faced can be changed, but nothing can be changed until it is faced." This is a pivotal moment for your ladyship's inquiry, and we will be hearing from a diverse and poignant array of voices, from the heart-wrenching testimonies of those who are bereaved to the invaluable perspectives shared by others devastatingly impacted by the pandemic. And my lady, as we explore Module 3, let's remember this, that this inquiry is not just a procedural exercise, but an opportunity to confront deep-rooted injustices and work towards a fairer, more equitable future. I'm not going to go into the background in any great detail. Your counsel, Ms. Cleary Casey, really set out the framework, I say respectfully, in a great way this morning. But the pandemic has laid bare the deep-seated inequalities within our healthcare system. Professors James Nasru and Lara Bakaras confirmed the ethnic inequalities in health in the UK, quote, are long-standing and persistent and have been researched and documented for several decades. On this basis, we consider it indisputable that the disparate impact arising from the pandemic of this nature was foreseeable. It did not have to be, however, inevitable, as impactful as it was here. You see, in the missed opportunities for countermeasures and early mitigation, that ethnic minority health and social care workers and their communities were so badly failed by those responsible for leading the response. You see, from the very outset, and forgive me if I repeat what has been said before, but I think it's necessary to repeat these statistics. It was evident that Black, Asian and minority ethnic workers were being disproportionately affected, not least through facing alarmingly higher rates of infection and mortality. 95% of doctors and 64% of nurses who succumbed to the virus in the early stages of the pandemic were from ethnic minority backgrounds. Here, there are chilling parallels with Grenfell. The disparity in the devastating and direct health outcomes for ethnic minorities were well known and widely publicised early in the pandemic. These numbers, my lady, are not mere statistics. They are a clarion call, irrefutable proof that systemic failures contributed to these tragic outcomes. And my lady, key questions for this inquiry remain to be answered. Why? Why were so many lives impacted and lost? And how many of those deaths were avoidable? You see, systemic racism in healthcare is a deeply entrenched issue, and the pandemic exposed it with unprecedented clarity. Do you remember when former Health Secretary Matt Hancock openly admitted, when being questioned by myself, that he was aware of and agreed with the assertions that there was systemic racism prevalent within the NHS prior to the pandemic? Yet, no effective action appears to have been taken by him or others to address that issue. During the pandemic, FEMHO members faced inadequate PPE, flawed risk assessments, higher levels of bullying and harassment, and a range of broader systemic biases that were systematically disadvantaged and left them more exposed, less protected, less empowered to speak up and raise concerns. Quite frankly, my lady, the law was flouted. The Human Rights Act 1998 and the Equality Act 2010, which were both pieces of legislation which were there to protect everyone's rights. So I make the following observations. Why is there no obvious examples of accountability within the NHS leadership for the appalling issues regarding the appropriate PPE for Black, Asian and minority ethnic healthcare workers during the pandemic? Why? Why no new measures coming from the NHS top brass indicating the recognition and decided steps to address the problems that ethnic minority healthcare workers faced? Why? Why no new policy or regulatory updates to indicate that the agencies will play a crucial role in the planning in the future pandemic? Why? Why no critical mass forming in the public consciousness around the direct relationship between racial health inequality and the disproportionate adverse health outcomes? A few more bullet points and then I'll sit down and finish. As foreshadowed by your counsel this morning, why the failure in PPE provision? Why the lack of risk assessments? Why the failure in the provision of equipment? We heard about the oximeter. Let us not forget or ignore the psychosocial and mental health impacts. You see, the emotional and mental toll on Black, Asian and minority ethnic health and social care workers and their communities during the pandemic cannot be overstated. One of my clients, Professor J.S. Bamra's testimony will illuminate how stress of increased exposure, economic hardship and the higher burden of illness and death led to elevated levels of anxiety, depression and burnout. The scrap plan to mandate vaccination as a condition of deployment added to a climate of fear and distrust. Furthermore, my lady, the emotional strain on healthcare workers who had to support patients' families, often unable to visit due to the restriction, we just heard about that, compounded their mental health challenges. The intersection of racism, economic hardship and social isolation during the pandemic had significant impacts on the mental health of Black, Asian and minority ethnic communities, exacerbating physical health problems and exponentially increasing their vulnerability to COVID-19. Root causes. Leadership, diversity leadership, was notably lacking. So, m'lady, as I come to the end of my opening, let me just say this. Recommendations and the call to action. As we proceed with Module 3, it's essential to address the systemic issues that have and may emerge as critical areas of concern. Perhaps we need to strengthen the public sector equality duty. We would urge a robust commitment to compliance with that duty. In other words, it wasn't complied with, it simply needs to be complied with. The duty of candour on public health bodies. You see, the Department of Health is just not learning the cultural lessons. Thirdly, as I said, promoting diversity in leadership and decision-making. Enhancing cultural competency in community engagement and looking at medical devices and equipment. So let me come to my conclusion. So in conclusion, this inquiry has a crucial opportunity to address these systemic issues with seriousness and resolve. By thoroughly investigating the impact of institutional and structural racism and inequality and implementing the suggested recommendations that I've outlined, we can work towards creating a more equitable and effective healthcare system. It was Eleanor Roosevelt who said, "It's better to light a candle than to curse darkness." Well, m'lady, the time for cursing the darkness of the COVID years has passed. We urge you to be that light, a beacon of hope and change. So shine brightly for all of those affected and lead the way towards justice, equity, and greater equality. Thank you.
Thank you very much indeed, Mr. Thomas. Right, well, I've had a great deal of food for thought today, and on that note, we'll draw matters to a close for today. I shall return for Ms. Sen Gupta, wherever she is, I think she's back there somewhere, tomorrow at 10. All rise.